The GELF criteria were initially developed to identify patients who had so-called bulky disease. And they included not only disease-related symptoms and organ compromise, but specific size of tumor recommendations. 3 lymph nodes of at least 3 centimeters, 1 lymph node of at least 7 centimeters. What we now use the GELF criteria for is to identify patients with follicular lymphoma and other indolent lymphomas who need to be treated, and others who might be able to be managed with a watch and wait perspective. So that's where it has transformed over the years, from being just what's bulky disease to who needs to be treated.
When a patient is diagnosed with follicular lymphoma, the most important thing is to establish this stage. And this is done usually through CT scans and a bone marrow biopsy. Most recently, we incorporated PET functional imaging because you may pick up sites that were not picked up by CT scan. But more importantly, you can pick up a highly active site by PET scan that would have otherwise looked normal enlarged lymph node by CAT scan. This is important because if you, let's say, stage a patient, you find like multiple lymph nodes above and below the diaphragm, and one of them have a very high SUV, which is a measure that we use to determine how functionally active a lymph node. This may give you a hint that there may be an active histologic transformation from follicular lymphoma to a more aggressive subtype, so like diffuse large B-cell lymphoma. This tells you that I should put the needle there to obtain tissue biopsy, and then rule out active transformation, because this can make a difference in treatment choices. So if you, let's say, stage a patient and the patient has follicular lymphoma, and you decide that they have a low tumor burden by the GELF criteria, and you want to put the patient on active surveillance, before you start therapy, I think it's important to repeat functional imaging to decide whether there is a transformation or not, because this can play an important role in selecting what type of regimen you would use.
Patients who have low tumor volume, do not have disease-related symptoms, don't have effusions, or any other of the stigmata of the GELF criteria, can just be most often watched and waited, careful management, close observation, but without the need to be treated. It's when the disease looks like it's growing, it's when symptoms start to appear, that's when discussions need to be initiated as when is the time to start treatment and with which treatment modality.